Hi, good evening, everyone. Can you hear my voice? Okay, so first of all, I would like to welcome all of you in MRCOG Part 3 exam preparation session. We will be discussing all the aspects of the exam, how to prepare it, what exam is about, how you can perform in the exam. So all those things we'll cover in this webinar today. Dr. Pooja is with me. She will be explaining all the aspects to you. Hello, Dr. Pooja.
Hello, everyone, and hi, Dr. Heather.
Yeah, hello. So we have a good audience. I think we can begin. It's a request to all of you that in the session, please keep your mics mute. And once we open the question and answer session, then you can unmute and ask the questions. So in this way, we will have, you can say, no unnecessary background noise. Over to you, Dr. Pooja. You can proceed now.
Okay, so good evening to all of you, and welcome to this introductory session. And this is a part of our new course which we have started for November candidates. This is the comprehensive extended course. So during the course of this session, I will tell you about the course. But let us talk about the exam first. And I know part 3 is considered the most difficult part of MRCOG preparation. This is because we are lost when we start preparing and we don't know what to do. Because till now, part 1 and part 2, you had a fixed syllabus. You had to read it, and the questions were all written. There were multiple choice or extended matching questions, and you knew how to read. You had the guidelines and everything. This exam is a talking exam. It is a speaking exam. So it's very difficult to decide how to start preparation. And many of you must be in that zone. But let me tell you, everybody starts like that. In the course of this presentation today, we'll try to find out how we can do this preparation. So all of you know about MedExam Expert. So we have been successfully running courses for part 1 and part 2 for a long time. The part 3 courses started last August. That was the first one was before the mid-September exam. And then we had courses before the November exam last year, and before the Feb exam and the April exam this year. The idea, these all courses which we have had in the past was generally a 1-month course, which was an intensive course just before the exam. The idea for this long course came when many candidates started asking about the next course, and because now there is a gap in the exam. So now the exam directly is in November. So the regular course will run as usual, but for those people who are waiting for the November exam, I'm sure there are 2 types of candidates who are there today. The first group is those who have already decided that they would give the exam in November. So they may or may not have started the preparation, and again they may be thinking or contemplating how to go about it. The other group of people are those who had started preparation but unfortunately could not get the seat for the April exam. And then now they would again apply for November. But yes, when you don't get the seat, the preparation again becomes slow and haywire because people were disappointed. I have friends who were preparing very well for April but unfortunately could not secure a seat. So then again, to start preparation, it is a difficult matter, to get into the tempo. So the idea of this course is slow, sustained preparation. Okay, so let's talk about the exam now. And So where are we now? So all of you have passed the part 2, and I think, in my opinion, part 2 is the most difficult part of the exam because it requires a lot of deep study and intensive preparation. You have to read between the lines. You should know each line. You read so many guidelines, and it is a never-ending theory to read. It is never-ending. So that, and then to reproduce that knowledge in the form of EMQs and the SBs, they are quite tough actually. And so that is the most difficult part of the exam. What I mean to tell you is now the most difficult part is over. This is easier part, but it requires a strategic preparation, which is the key to this part of the MRCOG. So, MRCOG this is the final part of the journey to the degree, and earlier it was known as the OSCE exam, and now it is called the Part 3, and earlier the Part 2 theory and the OSCE happened simultaneously, but now they have split, so it's a separate exam altogether. It is a testing of clinical skills, knowledge, and communication. So all the things are important. So it's not only knowledge, though I will not say that you don't need any knowledge. You definitely need the knowledge to be able to speak and talk, but you don't need too much in-depth knowledge as you require in Part 2. It is more about how you can communicate or convert your knowledge into your speech and explain or manage the patient. So it's easy for me to sit on this side and tell you, okay, prepare like this, but okay, there are general rules of preparation which we will be talking about, but please remember, don't follow anybody blindly. Each one of us will develop their own method of preparation, which is the best for oneself. So there is no hard and fast rule that this is the way to prepare. There are many ways. So once you listen, you can incorporate the good points when you listen to anybody, maybe to me or to your friends who have passed or to friends who are preparing with you. Try to listen to everybody, and out of that, take out those good points which you think you can incorporate in your style. So, and then make it your own style of preparation, incorporating the good points from all. So it's, as I said, it's a standalone exam now. And important thing is, once you have cleared the Part 2, it has to be attempted within 7 years, the first attempt. And 4 attempts of Part 3 are allowed. If one is not able to clear the Part 3 even after 4 attempts, they will have to repeat the Part 2 again. Hopefully, none of us is going to be in that situation. For the November exam, the dates are 4th, 5th, 6th, and 7th November 2019, and there are 4 venues, London, Singapore, Hong Kong, and Delhi. And the RCOG website says that the number of candidates in the November exam will be the maximum till now. So hopefully, most of you would be able to secure seats. So make it your best preparation. For any details on the exam, venues, dates, any changes which may come up, please keep seeing the RCOG website, which is very, very essential. I've seen people asking other people on Facebook and Telegram and WhatsApp about, questions pertaining to the exam. So the body which is conducting the exam is the Royal College. So keep watching, keep seeing the Royal College website, because there you will find the maximum information and the correct information. So don't depend on people to give you information, just find it yourself. So for those, most of you know these things, consider it as a repetition or a revision. There might be some people who are absolutely new to the exam, and there might be some who have already appeared, but it's good to listen to these things again. So it's a circuit exam, as you all know, and you will have 14 stations in the exam. Each station will be 12 minutes, in which you have 2 minutes of reading time and 10 minutes of actual time in which you are presenting the station. So it's a total of 168 minutes, which will determine your success in the MRCOG. So we have two kinds of stations, role player stations or the simulated patient task, in which there is an actor who simulates the role of a patient. And this includes the teaching station, in which the actor will simulate the role of a junior colleague. And when it's a patient, you have to be the doctor to that patient and ask questions and give your management plan. And if it's a teaching station, you are the senior colleague and you may teach a particular aspect or procedure or anything else to your junior colleague. So these are the stations where the communication with the patient or the colleague will be tested, along with the other domains which we'll be talking about. Then other kind of station is the structured discussion. This is directly with the examiner, who is actually the consultant, and you are the ST5 trainee, and there will be a clinical scenario situation given to you, and questions will be asked on that. These stations are a little different because here you use scientific language, and these stations are something as you have been doing in your own postgraduate exam, in which you are answering the examiner. There's no preparatory station, which used to be earlier. If somebody has given the exam in the before 2016, where there used to be a preparatory station, but all stations are active in the exam now, so you have no break. So you continuously go around the circuit. They also have the concept of the lay examiner. Lay examiner is again a trained examiner who is not a doctor, who's a lay person, and they also will be marking you basically mostly on the communication skills and your attitude towards the patient and your clinical knowledge and your confidence. So there will be few stations which will have 2 people along with the actor sitting. Those are the lay examiner stations. And needless to say, they carry the maximum marks, because both the clinical examiner and the lay examiner is going to mark you in those stations. So once you go there in the exam, you stand in front of your that station which has been allotted to you, and then you move into the circuit. So everybody will move into that circuit. There are various cubicles, and the role player and the examiners are sitting inside the cubicle. The instructions for the exam are pasted outside on the cubicle wall, and the same instructions you will find on the table when you go inside. So even if you miss anything outside, the same instructions or the same station will be given to you inside, so that if you miss something outside, you can read it. So as I said, no break and 168 minutes. Now, what do you study in this exam? The modules are the same as your part 2. Teaching, core surgical skills, post-operative care, antenatal care, maternal medicine, management of labor, management of delivery, postpartum problems, gynecological problems, subfertility, sexual reproductive health, early pregnancy care, gyne-oncology, urogynecology, and pelvic floor problems. Also, something related to these modules, which may be different, unique topics may also come, which may have some relation to one of the modules, but the topic may be different. We'll be talking about that. In this course, we'll be taking these 14 sessions of each module separately, so that we can concentrate on each module. You should remember that though the modules may be small or big, like if you see maternal medicine, it is a very vast module. So all kind of questions can come from it. There are variety of medical problems which may present in pregnancy, which come in maternal medicine. And if I can compare it to something like subfertility, it is still a very, it is comparatively, relatively a smaller module, because the topics are maybe limited and fixed. But the important point to note is that in from both the stations, both the modules, one station is going to come. So the importance of subfertility is equivalent to maternal medicine. So while you are planning preparation and planning the time you give to each module, you should keep that in mind, that you should give equal time to each module, because the yield of each station, module will be one station. So it should not be that you are reading a big module and you continue reading it and spend too much time on it, and then you are not able to do the other modules, which will again fetch you equal marks. So that is an important thing to note. When do you start study? So whenever you decide that is the right time. So you know what has been happening since last year is that the number of candidates who want to appear for part 3 is very, very high now. And you should know that there'll be another part 2 exam in July, and the candidates who pass in July will also be planning November exam. So the number of the pool of eligible candidates for part 3 is increasing. So whenever you get the chance, you get the seat for the exam, it should be your best attempt. So because I know people who suddenly got an email from RCOG for February exam, but they thought they were not well prepared, and then they had to forego that attempt, and then they could not get a seat in the April exam. So you should be now ready with your preparation. So once you give the exam, it should be with your maximum attempt. It should not be half-hearted, because getting a seat in the exam is also not guaranteed nowadays. So you have to be consistent and thorough with your preparation all the time. I know it is difficult to maintain the same tempo over a period of time, but that is the key. So as soon as possible, so if you decide today, start studying today, and you should keep studying till the exam. Now, the important thing in the exam is the domains. This is how you are marked in the exam. And there are 5 domains which will be tested. That is information gathering, communication with the patient and the relatives, communication with colleagues, applied clinical knowledge, and patient safety. Each domain, so in each station, either they will be testing 3 domains or 4 domains. It is unlikely that all the 5 domains will be tested in one station, but at least 3 and up to 4 domains most probably will be tested. So for each domain, the marking goes like pass, which is 2, borderline, which is 1, and fail, which is 0. So depending on the station, the marks are there. As I told you, if it's a lay examiner station, the number of domains tested will be more, and then the total marks of the station will be more. So all the stations, they do not carry the equivalent marks. Also important to remember is that you don't need to pass in each domain. There is a cutoff for the exam, and if you pass that cutoff, you pass the exam. But if a person is not able to clear the exam, they actually tell you in which domains you were not up to the mark. So that will be mentioned in the result. But if you pass the cutoff overall, you pass. But again, for that, you have to perform in each domain well. So if you see, if I go back, information gathering is something which you have been doing time in and time out throughout your career in obstetrics and gynae. So the information gathering means in a particular station, whether you are able to extract the relevant and appropriate information. That is information gathering. So it includes history taking, examination, and investigations which you like to order, and the interpretation. So this is the information you gather to decide what is the diagnosis and what is the management. So it includes all history taking, examination, and investigation. It's important to note that history taking is also involving communication with the patient, because how you ask the question, sometimes they are sensitive questions that will determine whether you get the answer, whether the patient is or the role player is giving you the proper answer. So again, so there is a slight overlap between the domains. It's what I mean to say. So that's information gathering. We will talk about history taking in detail in a while, because that is something which you should be very, very thorough with and don't miss any points. Communication with patient and relatives is something which actually, if you master it, it is the easiest to score. But it involves certain finer points which you need to understand during the course of your preparation. So it's not only about what are you saying, like you have the knowledge about a particular station and you say all the right things, but the important point is that how you are saying it to the patient, how you are explaining your behavior, your body language, your attitude towards the patient. Are you listening to the patient? That is again an important thing. Are you addressing the patient's concern? So you should not be going on and on like a lecture. Okay, this is what I want to tell the patient and I'm going to tell it in these 10 minutes. It is how you understand what the patient is concerned about and you are able to address that concern and satisfy the patient, which is important in this exam. Are you telling the information in a language that the patient can understand? That's important. You all know that we should be avoiding scientific jargon, which the person sitting in front of you does not understand and feels more scared because they're not able to understand what you're saying. So telling it in the patient-friendly language which the patient easily understands is another important part of communication. So you have to analyze. So, and it's not that you should be speaking first, you should be listening to the patient, not only listening to the patient's words, but even trying to analyze and see and visualize and observe the patient's body language, how the patient's tone as well, because that will give you an idea what the patient is trying to, or the role player is trying to tell you. You should remember, these are not actual patients in the exam, they are actors. They have been given a script, they have been told to act out a role, they have been told to cry or to become angry. Depending on how you're responding to them, they change their attitude. So what they're telling you through their words and also through their action and temperament and body language is very important for you to understand. Now, this is something very simple which we do in real life. So when you are conversing with somebody, I'm not talking about a patient, even if you're conversing with some friend or a person you've just met, you analyze how the patient, the person's tone is, how he's behaving, whether he's arrogant or modest, or whether rude or polite. So you do analyze these things, and then you decide, okay, this person is, okay, maybe other person is sad. So you decide based on these visual cues, auditory cues, and the cues given by the body language. The same thing you have to do in the exam. It's only that it's an exam situation, so you are overwhelmed. Oh, I'm in the exam. Oh, I have to pass this. I have to think about patient safety. Instead, if you keep yourself calm and analyze the situation as you would do in your real life, it becomes easier to pass the exam. And I'm telling you, this includes my own experience, being calm makes you much more confident. And even if you, the knowledge part is a little bit, you don't remember, or you just could not read that particular point, it will not matter as far as the overall result is concerned. So please keep that in mind. Important. So the communication comes in, as I said, in this domain, communication with the patient, that's self-explanatory. And this will be tested even by the lay examiner. The information gathering, as I told you again, is involving communication, because the way you are asking the questions will determine the answer. Suppose there is something sensitive like some sexual problem the patient is having, unless you are able to ask in a manner which is non-threatening, which is non-judgmental, the role player is not going to answer you. It's a case of, if it's a case of a domestic violence, you have to make the patient comfortable. And this is information gathering. So even if you know, oh, this is a case of domestic violence, they are all cues in their station. But you're not able to gather that out of the role player, your station remains incomplete. So please remember that. And the communication now comes in the communication with colleagues. So the communication becomes very important. So communication with colleagues, they are tested in both simulated patient tasks and structured discussion. So structured discussion, you understand very easily. So it is, it's the examiner sitting, and how you communicate with a senior colleague, with your consultant, is what is the communication with colleagues. So you should be confident in your answers. You should be using scientific terms here, because it's not a patient, it's your own senior colleague who's sitting in front of you. So use scientific terms, modulate your answers in, you know, in a proper manner. This we'll be discussing because structured discussions, most of the people, they find it difficult. Why? Because in a simulated patient task or a role player station, at least you know you can take the history, and if you're good in communication, you can take the history and explain the management plan. But structured discussion, the term itself tells you what you have to do. Your answers should be very structured. It should not be haphazard, because you'll be, even if you're knowing it and your answer is not structured, you will not get more marks. So structured discussion is something most of the people, including myself, have found difficult to answer. So again, it will require more of practice. And when you're reading outside, you have to again start structuring. Okay, these are the probable questions, and this is how I'm going to answer. The next domain is applied clinical knowledge, which is self-explanatory, and it will test your knowledge, whatever you have read in the part 2 exam, your guidelines, your strategy, NICE guidelines, and your drain top guidelines, all the different kinds of materials, your TOG articles. Now the question everybody will ask here is, how much can we read it again? So it is practically impossible for anyone to revise all the guidelines now for part 3 what you did in part 2. It is not possible at all, and it is not required also. So something, if you remember, see, suppose you are doing a case of hyperemesis station on hyperemesis gravidarum, and obviously you won't remember the details. Suppose you've given the exam in January, or you've given the exam before that, part 2 exam. You will not remember the details now. But when you are doing the station, just quickly go through maybe the recommendations of the guidelines or the important bullet points you may have marked. Just go through that. That should be enough. You should concentrate more on speaking and communication now. But yes, without clinical knowledge, obviously you won't be able to even ask questions and even give answers. So a background clinical knowledge is essential. But what I mean to emphasize is the difference from part 2 is that you do not need very intensive study, but you should be knowing the basics definitely well. Now another domain is patient safety, which actually confuses everyone, because everyone I talk to will keep talking about what are the patient safety points, what are the patient safety points in this station. Actually, if you think, it's fairly simple. Anything which makes you a safe doctor, safe for the patient, is coming under patient safety. So what do I mean by that? Suppose what history you ask the history of allergies. So that helps you to decide which drug you should not give to the patient. This is a patient safety point. So don't forget allergies in any station. Now, in a case of bleeding, a miscarriage, a termination of pregnancy, you ask about the blood group from the patient, because if it is a Rh negative, you need to give anti-D. Unless you ask this, you will not know. So it is again an important safety point for the patient. Then, if you are doing a postpartum case and you have to examine the baby or the mother, you say to the examiner or to the patient that I am going to practice hand hygiene. That is a patient safety point. Taking into account patient's dignity, maintaining it is again coming under patient safety. Assessing the thromboprophylaxis risk in a particular case and deciding whether a low molecular weight heparin has to be given is a patient safety point. In a young patient, and we'll be doing sessions on young adults, offering contraception, telling about safe sexual practices, screening for sexually transmitted disease is a safety point. It may not be part of the station directly, but this is something you should remember. These are some examples of patient safety you should be using in your stations. And this, if you read, if I tell you, if you want to know what, where you can read about it, is the Lisa Joel's book, which is the first book I think you should start reading if you start preparation, because just go through it, because it tells you in detail about the domains and how the domains apply to different modules which we are going to study. So if you read that, you will know, look, okay, in this module, these will be the patient safety points. This will be the clinical knowledge they are looking at, and this will be how the communication with patient works in this module, and so on. So this is how we should be, thinking. And each station, when you're doing it, when you're practicing it, think about the various domains and how can you apply it to that particular station. So it's a thinking exam. You have to think and analyze what you're trying to say, what you're trying to ask the patient in the domain. You should be critically analyzing it later once you do it. Okay, so next thing is outside the cubicle. So now you are in the exam, and just before that, I will just talk little more about the domains, like because these examples you can remember. So communication with the patient. Patient comes in early pregnancy. You ask, oh, is it a planned pregnancy? And she says, yeah, doctor, I was planning it for a long time and so happy. So offer congratulations. Unless, but you have to remember, unless you know it is a miscarriage. You already have an ultrasound report which shows it's a miscarriage, then don't just, because you remember that, oh, it's a planned pregnancy, congratulations may come to you very naturally because you have practiced it again and again, but remember that. So you have to modify your knowledge according to the situation. That is why I say that, just blindly remembering templates for any station or any module doesn't help. You have to actually analyze and think and change and modify yourself in that situation. Okay. When you are talking and asking sensitive questions, as I said, in information gathering, which again, it involves information gathering as well as communication with the patient. When you want to ask a sensitive question, signpost. Okay. I'm sorry to ask you this, but it is essential, for my management plan. So you might find my questions very intrusive, but I would like to know this. So you signpost the patient and say that, okay, I know this is an embarrassing question, but I'm going to ask it because I need to plan your management. So this comes in communication. Also, signposting is a term which we use even for breaking bad news. We will be discussing breaking bad news in stations, and we also do it as a part of a topic discussion, which I'll be coming to. Like, there's a cancer patient who has got a report, histopathology report, which shows she has endometrial cancer. So, or it's a pregnant patient and the baby has an anomaly which is not compatible with life. You have to break that bad news, say that I'm sorry, but I don't have good news for you. So these are certain lines which should come naturally to you. But again, as I said, no congratulations if you know already there's a bad news. So there are some things which should come naturally, but again, you have to analyze yourself in that situation. The communication also involves empathy. So if you know that, okay, the patient has got cancer and feel bad for the patient, obviously you cannot start getting emotional with the patient, but yes, you should have empathy that the patient is going through a bad time, a bad phase, and your tone, the manner in which you speak, your body language, the attitude in which you're sitting should all reflect that. So it's not only about words, it's the tone of your voice, the volume of your voice. The volume should go down. The tone should be calm and composed, but it should be empathetic. The body language should be showing the patient, yes, that I care for you and I am there to support you. Another important point is honesty. Suppose a complication has occurred in a laparoscopy or a hysterectomy. You have to be honest about it. I'm sorry to tell you that, but this is what has happened. The patient will become angry and all, but yes, but you have to be honest that if a complication has occurred, and even if you have to break the bad news, you should not go beat around the bush and try to not tell the patient. You have to be honest about whatever report or whatever diagnosis you have in your hands. You have to tell the patient. The way will differ. And we were talking about avoiding medical jargon, and you have to understand what is layman terms. You have the patient information leaflets for various disorders in which patient-friendly language is given. And not only that, you have even the layman terms given in the RCOG website, as well as also it is, if you read books like Get Through MRCOG, the layman terms and the layman terms for many of the disorders or medical diseases, it's also given how to explain that in layman terms, so that you should keep reading again and again so that it comes again naturally to you when you explain. You can use aids to explain to the patient. You can use something like a diagram and explain, okay, this is the uterus, this is a tube and the ovary, and there is a cyst in this ovary, in your left ovary, which is filled with fluid. So you can draw a diagram and explain, which gives a better visual impact to the patient. It improves your communication. Information gathering we'll be talking about, and I will tell in the history once we do the history taking. Then patient safety, I want to include certain more points. Suppose it's a high-risk pregnancy, so you should understand it is a high-risk pregnancy, and you manage according to that. Like if it's a high-risk pregnancy, it's a preeclampsia or a diabetic patient, you may increase the number of visits and you tell the patient, okay, now because it's we are going to monitor you, so the number of visits will increase. Or it's a intrauterine growth restriction in the baby, the number of visits, the number of ultrasound scans will increase. So analyzing it's a high-risk pregnancy and then taking action on it is patient safety. And important to explain the patient the risk of alcohol, smoking, and obesity. So now when we ask the patient, no, it's important, but like I've seen in many candidates, and when they ask, okay, do you smoke? And the patient says yes. And then they go to the next question. Oh, you do you take alcohol? You have to act on what the patient has said. So that's where the okay, somebody is asking, can I hear this session later? Yes, it will be recorded and you can hear it later. So you have to respond to what she said. If she said, okay, she's a pregnant patient and she says, I smoke 5 cigarettes per day. So you should not just listen to it and not take any action on it. You have to tell the patient, I'm sorry to point out that, are you aware that smoking is harmful to your baby? And she will say yes or no. Then you explain, okay, smoking can cause this much harm to the patient. I'm not trying to sound judgmental. Have you thought about quitting smoking? She may say yes. And you say, do you want, oh doctor, I tried, but I did not succeed in that. So you say, do you think more help would be required, or more support will be useful? I will refer you to the NHS Stop Smoking Service, or I'll write back to your GP who will direct you to people who will help you and support you in this endeavor. Something like that. So you should always respond to what the patient is saying. Similarly with alcohol. What I missed when I was telling you about patient safety earlier is like, you suppose there is a situation in which you cannot manage it. Now by the term you cannot manage it, I mean that you cannot manage it in the exam, because in the exam you are the ST5 trainee, you are not the consultant. So in real life you may be managing all kinds of complicated procedures, and many of you will be consultants who will be doing all their cases on their own. But here, please remember, this is the MRCOG exam. You are just the ST5 trainee. So don't try any heroic things. Suppose you were doing a diagnostic laparoscopy under supervision or without supervision, and then there is a bladder injury. Don't say that I am going to repair it. You have to call your consultant. So recognizing your own limitations as a surgeon or as a doctor, and then referring to a higher authority or a senior colleague in times of that is again patient safety. Because if you're doing it yourself and you're not trained to do that, or you're not being signed as competent on that, that means you are endangering patient safety. So this is again a point you have to remember. Patient safety is determining whether there is any hidden agenda, which may be domestic violence or bullying in a teaching station. We'll be talking about bullying in detail later. And that is again patient safety. Risk management, we keep on talking about risk management when we study in MRCOG. So risk management, in any case, there is a complication which has happened. You set up the risk management team. Who will be the risk management manager? What are the steps for risk management? How do you find the report, you debrief the patient, you file an incident report. All these things should also come naturally to you. And applied clinical knowledge is to tell the patient a management plan. And it should not be the management plan which you think is best for the patient. So definitely you should, if it's one particular plan of management is definitely recommended, you should say to the patient, but you should give always the alternative plans of management. Like if you have heavy menstrual bleeding or a fibroid, so there can be medical management, there can be a uterine artery embolization, there can be endometrial ablation, or there can be a surgery like myomectomy or hysterectomy. You should give all options. You should explain all the options, pros and cons of both, and let the patient decide. So your job is to help the patient decide on the best management plan for herself. Applied clinical knowledge, if you see in maternal medicine or in antenatal care, is deciding which patient should go under the consultant-led unit, why they should be in the consultant-led unit, what monitoring extra would be required for them, and explaining that to the patient. Counseling about any procedure, like maybe a laparoscopic hysterectomy or hysteroscopy, taking consent. So explaining about the procedure. You should have the knowledge about the complications of the procedure, and you should be able to explain to the patient that yes, these are the risks which are associated, and you should be honest and forthcoming about all the risks the patient has. Okay. So now you have prepared for the exam. You know your modules well. You know what domains you will be tested upon. So now we have reached the exam day and we are standing outside the cubicle. So the first bell rings and it tells you now you have 2 minutes. Before the next bell rings, when you have to go inside the cubicle and face the role player or the examiner, as the case may be. So when you're standing outside, what do you do in those 2 minutes? So most of the people think that 2 minutes are, it's a very short time, and it just passes fast. And it is true, it just goes by very fast. Sometimes you may find, many pages outside, and you get so tense. So how am I going to read it? Again, staying calm. as I tell you again and again, is the key there. You stand outside. When you read it, you ask yourself few questions. Who are you? So it will be written, okay, you are the SC5 trainee or the SC4 trainee. Generally, you will be the SC5 trainee. The next question is, where are you? So what is the situation there? I mean, in the station. So it will be written, you are the SC5 trainee in the fertility clinic, or the emergency ward, or the labor ward, or the gynae outpatient department, OPD. So you know, okay, I'm there, that you should analyze at that particular time. Like, what is the situation like? So sometimes there may be a letter from the GP. Sometimes the midwife may have called you for an emergency. Sometimes your consultant had asked you to see that question. So see what is the situation. Now, see the name of the patient, see the age of the patient. The station will change if it's a 15-year-old from when it's a 40-year-old. So see the age of the patient, and you should remember that it's not always that the age of the role player will be same as what is written in your station. So you may get confused. I mean to say is the station or the instructions say that the patient, it's a 15-year-old, 15-year-old, so it's a young adult sitting there, and inside you go, there's a middle-aged lady sitting there, but that is an actor. That doesn't mean that it's a middle-aged lady in your station. The station says it's a 15-year-old, so remember that. So don't get confused. It's an important thing. So these small points are very important, which when you go in the exam situation, you may not remember, but this is something which you have to remember. Then you see in the station, what is the main finding? Something must be about that the patient has a complaint of a premenstrual syndrome, or the patient has a complaint of a urinary incontinence, or the patient has heavy menstrual bleeding, or the patient has sickle cell anemia. So try to understand what is the main finding, and then make your differential diagnosis. Okay, she's at 34 weeks with sickle cell disease, and this is the problem she's having with the rupture of hemorrhage. So understand the situation and make your diagnosis. Write those points which you need to ask the patient and which you want to tell the patient. The most important point, just not write down. So basically, when you go in the exam, they give you a notepad, a small notepad and a pencil for you to write down. And they take it back at the end of the exam. They will take back the notebook at the end of the exam. They don't let you carry it outside. But during the exam, you carry it to each station and you note down. So use that pen and paper. Now, how will you get used to using that pen and paper is when you started now, when you're preparing. Now, what things I'm telling you, they are with experience, and you should try to listen and incorporate them. Now, you may not like everything I'm saying, but I think this is important because straight away when you go in the exam, it is difficult to write down. But when you're practicing, say you are practicing a station with your study partner and there's a 2-minute reading time. So use that 2-minute reading time to again write down in your notebook the same way you would be doing in the exam. So when you are practicing it day in, every day you are practicing that writing in those 2 minutes, the important points of a station, it will become much easier in the exam. Mark my words. Also, I tell to all the candidates who join the courses, when the course is also going on, whoever may be presenting, obviously the person who's presenting needs to do that, but the other people also, when you get that 2 minutes time and the slide of that station is projected on your screen, keep making those notes as you would do in the exam. Only then you will have the practice and the confidence to do it in the exam. It is very difficult to, do something first time in the exam and then do it well. So this is something you now should get used to practicing. And as I said earlier, there are some stations you will find that there are multiple papers there. So it becomes a little difficult to read everything in those 2 minutes and write also and to understand also. but don't get hassled. There may be 1 or 2 odd stations in the exam which will have multiple papers. Whatever you can read in those 2 minutes, try to do that. Once the bell rings, you can take some time extra, or you can go inside, and if it's a role player sitting there, you can just excuse yourself that I'm sorry, but I just need to go through your notes, so give me a minute. So she will say yes, and then you read it there, and then start talking as you would. So there's nothing wrong in that, but again, stay very calm in this situation. Also, suppose you do a station very badly. So I'm still outside the cubicle. So suppose the last station, you knew nothing about that, or you think that you did not perform well in that station, you could not answer the questions of the examiner or the role player. Don't keep thinking that in the 2 minutes in the next station, because otherwise you are going to lose on that station also. So just whatever happened in the previous station, just leave it there, go on with and do a fresh start every 12 minutes. Finish the station, just finish it. Think about it later once the exam is over. In the next 2 minutes, be very alert and focus on your next station. This is important. Okay. So when you are entering, and once you have written all the points and the next bell rings, go in smiling. It's not that you have to start laughing or you have a big smile. So generally you should be seeming to be calm and pleasant to the patient, unless it's a breaking bad news. Obviously, it's you know that the patient has cancer. You don't start smiling and say hi, hello. Obviously, you will be somber and you would be serious in those situations. Otherwise, when you go in, have a smiling personality. I don't mean you have to smile very, prominently, but yes, you should have a smiling face. And then you start that, okay, I've been, hello, may I check your name and age? Or you may call the name of the patient. She'll say, hey, yes, doctor, hello, how are you? You say that I am Dr. This, the ST5 in the clinic or the ward or the labor room today. And may I check your name and age? And she will tell you her name. And okay, doctor, I'm 30 years old. Okay, so you say, how would you like me to address you? Generally, it will be on first name basis. And then you go on. Try to use the word I instead of we. It's something, generally people tend to, please mute your mics. Excuse me. Somebody's mic is on. Okay, thank you. So, we tend to use the word we. We will do it for you. We will, make an MDTA. We will refer you to an. Try to use the word I. You are the treating doctor there.
My mom, of course.
Okay, 1 second. Dr. Huda. Okay. Sorry. Okay, I did not change the slide. I'm so sorry. So you have gone inside the cubicle, you go smiling and introduce yourself, and then confirm the name of the patient and ask her how would she like you to address her, and try to use the word I. Take responsibility of the patient. Don't say we. Say I. We do tend to use the word we in these cases, but it's better if you say, okay, I'm going to refer you to that, or I'm going to talk to the consultant about it. Okay. And you have to set the agenda. So how do you set the agenda is that, okay, I have got a letter from your GP that says that, or I understand from your notes that you are suffering from or you are having this problem. Can you tell me more about it? So initially, it has to be an open-ended question. So let her speak more about her problem herself, and then you set the agenda. So you say that, okay, before I discuss the management plan with you, I would like to ask you a few more questions to know more about this problem or to know more about you. I would like to examine you, and later on we'll discuss your management plan, and I'll write back to your GP and give you some written information. So once you set the agenda, even if you're not able to complete the station later, you are able to at least, the examiner knows that, okay, she knows the written information has come. So suppose the 10 minutes are over, whatever you say after that doesn't matter, and the other candidate will anyways come into the queue. You have to move to the next station. So don't waste time on that. So if you have told earlier, at least the examiner knows that that, okay, and a patient information leaflet has to be given to the patient. So set the agenda in the beginning, ascertain concerns and knowledge. So you have to ask, so she says that, oh no, doctor, I don't want a vaginal delivery at all. So you have to basically say, okay, I can see that you are very anxious, but can you tell me the reason why you don't want to have a vaginal delivery? So you should try to find out why she's saying what she is saying, and knowledge also. So the patient says, patient is a known case of sickle cell disease. So, and she's on treatment. So say that, do you know more about it? What do you know about it? So that you know that what is her knowledge level. So that when you explain, you don't explain her the things she already knows. You explain her further. Then comes the information gathering, which has to be very structured, which I'm going to talk in detail about the history, which is a very important part of your station, because unless you are thorough in it, you will never be able to finish the station. Because if you know how to take the history, you know what things to ask, you will do it fast, and then you will have time even to explain the management plan to the patient. But if you are thinking, okay, what is the next question I should ask, and you slowly keep asking the history, the 10 minutes just go like that. Then information gathering will include the structured history, examination if it is required. Always when you say that I want to examine you, I will like to examine your tummy and for you from down below, explain her what you want to see. Justify that I am examining you because I want to know the size of the womb or the size of the ovaries, and I want to feel if there is any pain there. So then you have to justify that I'm going to examine you because I want to get this information. And then if the investigations are given to you, that is a part of the information gathering, and together you interpret and decide, okay, this is the diagnosis and this should be my action plan for this patient. Always check patient understanding. Suppose you explain to the patient, okay, this is what is an ectopic pregnancy, you check, okay, am I making myself clear? So anything else you want to know, anything else you want to ask. So in between, keep checking whether the patient has more questions for you. Don't keep on speaking as a monologue, as a monotone. In the end, you can just summarize if you have time. Again, depends on how fast you have been in history and how much information you have been able to gather. Provide the written information. This is a very, again, I think people please, as Dr. Heather has already requested you, please mute your mics because it disturbs me and stops my train of thinking, please. So you provide written information in the form of patient information leaflets. Even if you have explained everything, you definitely need to give them a written information so that the patient goes back and reads it again, and if they have more questions or any queries, they can ask. And then you close the session with something, okay, I will fix an appointment with the consultant as soon as possible, or I will fix an appointment with your husband, or you need to come after 2 weeks for an ultrasound scan. So close the session, okay, now I'm giving you this information and this is what next you want to do. So this I've already told you, communication skills are important. And this also I've told you, the voice, and this is the red letter line, listening to the role player is the most important thing you can do in the exam is listening to the role player, because that will help you in information gathering, that will help you in communication with the patient, that will help you to apply your clinical knowledge to the situation, and that will help you in patient safety. So listen to the role player, because they have the script, they have all the details, they will give you clues to your solving the station in a nice and comprehensive manner. Empathy, acknowledging emotions. If the patient is crying, I can see you are very upset. Patient is angry, I can see that you are very angry. Acknowledge it. It shows to the patient that yes, you are taking into account what they are feeling. Non-verbal communication, already I have told you, your language, your tone, your body language, your attitude is all important. Combination of open and closed questions. That means start with the open question and then go on to the closed questions. We will just talk about in the history. Targeted history. So there is something which is a general history which you ask in all the cases, but there is some targeted history which is pertaining to the module you're talking about. Like in menorrhagia, you'll be talking about in detail about the bleeding. It's a case of urinary incontinence, you will talk more about the urinary problem, and so on. Simple explanation, information in chunks, checking understanding, be honest, apologize well relevant. Okay, this I didn't talk about earlier. So apologize. Okay, some complication has happened. Say, I'm very sorry that this has happened. It doesn't mean that you are responsible for it. It could have happened in each patient. It is just empathizing with the patient's situation and say that you actually are in support of the patient. So you say that, I'm sorry that this has happened. Duty of candor, be honest. Okay, I will go to the history in detail a little later. How to prepare is now there's study material, which is, I think, on the internet. There is wide variety of study material which is available to you in the form of the guidelines and the strategy, which is so all material that is coming from the college, and there are various books which I will just enumerate. Then there are so many templates and courses. Study material from that also is available. Then there are courses like the course we are running, and there are on-site courses which occur before the exam in London or wherever the venue may be. And third is preparation with colleagues. So you can have 1 or 2 study partners, and this is a very important part of the preparation actually, because that allows you to speak, and you need to speak every day when you're preparing. So you should, if you don't have a study partner, you should start finding for a study partner. And again, it depends on what the rapport is with the other person. So once you do 2-3 sessions with the study partner, you will be able to know whether the rapport is building, whether you are gaining from that discussion or not. And also depends on the time zones, whether both the people are free at the same point of time. So it's a lot of permutation and combination. But if you find a good study buddy, there's nothing like it. It will help you immensely in your preparation, more than anything else. So please remember that. And ideally, 3 to 4 times a week, if you are able to practice with your study buddy at least 3 to 4 stations in a day, it is very good. Okay, it's not only, and the study partner should be such that gives honest and critical feedback to whatever you have said, so that you keep improving. And practice is the key. So I've written few points about the preparation. This slide I just made now. So these are the aspects of your preparation. First is read. What do you read? So you read the books on part 3. You read the patient information leaflets from the RCOG. You read templates which have been made by other candidates or which have been given in courses or which we will talk about. You read the guidelines or the strategy as and when necessary. Not everything, you won't be able to read, don't try it also. But yes, whenever necessary, you read the guidelines. The next part is listen and see. Now this is, listen and see means you see the videos. and listen to them. So there are various videos which are available on the net, which are from the RCOG. There's the paid resource with the full circuit with videos, which is very important to do. The Lisa Joel book has certain videos, and there are many videos on the internet from the RCOG. There are in the videos from Strategy. So you have to listen. So the videos will be there will be an actor who will be the doctor and an actor who will be the patient. So you have to listen to how they are communicating, the tone. Again, see all the things we have just talked about, the tone in which they're talking, the way they are asking questions from the patient, way they're asking the sensitive questions, all that stuff, and see how the expressions are, and how is the body language of the doctor changed with the body language of the patient. So all these things you have to analyze. When you see the video, it's not just to listen to the words, it is to see and analyze how the conversation is going on. So similar type of thing should happen in your session. So listen and see means see with your eyes and see with your mind. Then talk and discuss. So the third thing comes, talk and discuss, is with your study partner or people you are preparing with, or maybe when you're doing a course, like right now we are talking. So you present the case and then get the feedback and discuss it. So that is talk and discuss. Fourth point is write. I find this very useful, and since the exam is in November, we are now in May. You definitely can spend time in writing. Now what I mean by writing is, once you do a station, write down the points in that. Okay, you may write it in the form of full lines. This is what I used to do. I used to, the stations which I have prepared well, I can't say that I've prepared all the stations. The stations which I have prepared well, I have written the full conversation with the patient. Hello, I am Dr. Pooja. I am the registrar in the clinic today. May I check your, I used to write it each time. And then pertaining to the case, okay, it's specific questions you want to know. So I want to do this examination, and what do you want to explain? So write in the form of templates, or you may write in the form of domain. Okay, that's in this case, in the patient safety domain, these are the important points. In the communication of the patient, this is the important point. So all these things. So write. The usefulness of this writing will be evident or will be apparent to you before the exam when you revise. You can just read your template or your notes on the case, and you will get a wealth of information which you will not remember, because what you are studying now, you can't expect to remember in November. But if you have analyzed it carefully and written down what you have analyzed, when you read it later, it will come back very easy to you, and it will help you like anything. I always tell once we do the course, after the session is over, because they are long sessions, the sessions last for 3 to 4 hours. It's very difficult to remember everything which was said. But if you keep making notes, and then next day, if you sit back and analyze, okay, we did these 5 stations or 7 stations, I'll make note of that. What was discussed yesterday, what the presenter said, what the mentor told, and what you think. Analyze it and write down. And by the end of the course, you have 70, 80 stations with you. You revise it. Most of the things will come from those 70, 80 stations only, because the most important topics are always similar. Next is record and listen. This is another way of preparation. One is doing with your study partner. The other thing is you record your own stations. So when you're not doing it with your study partner, when you are yourself reading about a station, record it in 10 minutes. Okay, maybe you speak from both the sides as a patient and as a doctor, and record and see how you're doing, and then listen to it. Again, analyze it. Are you communicating nicely with the patient? How's the tone of your voice? You analyze it. Or you may record, and then later when you study with your study buddy, you can ask them to analyze it. Send the recording to them, ask them to analyze it. And do it for your study buddy yourself. So this way, you keep on analyzing yourself, and you will keep on improving. So you will see changes coming up once you do this practice. In 1 month, 2 months, you know that I've changed from level 1, and I go to level 4. And then by the end of the, before giving the exam, you go to level 9 or 10. And then talk again, means you record, you listen, and then you analyze, and then talk again. And this cycle should continue. So when you're preparing, I think all points are important according to me: reading, listening, and seeing the videos which are available, talking and discussing with your study partner or your group or with your course friends, writing down the important points in the form of templates or points of the domains, recording your own voice, listening to it later, and giving your, analyzing it yourself or taking feedback from your friends, and then talking again. The more you talk now, the easier it is for you to talk during the exam. So just quickly, as I told you, guidelines, PILs, talks, books, as I said, Part 3 MRCOG by Lisa Joels and Edward Neal. It's a very good starting book. Read it cover to cover. And there are 12 stations in that book, which are one from each module, and they're very well explained. There are videos in Lisa Joels, which are very good. Please do it thoroughly. I would say you should again revise Lisa Joels before the exam. You should do it once. Another important book which I absolutely love is The Task for Part 3 MRCOG by Mukhopadhyay and Sule. This was a book which came in last year, 2018. It has got around 70-80 odd stations. Explanations are very nice, and they're very, very important stations. Please do this book. And those who are going for November, at least do the book twice, thoroughly. It will help you a lot in the exam. Third book, which I personally like a lot, again, Clark and Kumaraswamy Get Through MRCOG Part 2. The latest edition has come in 2018. And the very unique features of this book is that they give you very beautiful lines to be spoken in various kind of situations, in various kind of stations. And again, I used to read it multiple times. The stations on audit and risk management, clinical appraisal are given very well in this book. Also, some of the structured discussions are nicely given. So I definitely recommend this book. Another book is OSCE for Part 2, Hollingworth and Reimer. This is a little older edition of this book. I don't know whether the new edition has come, but this book has good structured discussions. So if you concentrate on these 4 books, I think it's well and good. If you can do each one twice, I think it will be very, very good. Let's go on to the history taking. Before I start the history taking, I want to emphasize on one point. Your history taking should not take more than 3 to 4 minutes in any point of time, because if you take history for 4 minutes and you allow the role player to speak, who will speak for at least 2 minutes, 6 minutes are over, then you get 4 minutes to explain your management plan and to answer the patient's concern. And then she might have more questions to ask you, and you have to give the information leaflets and call her for the next appointment. Unless you do the history in 4 minutes, you will not get these 4 minutes for talking in the end. So suppose now you take the history for 6 minutes or 7 minutes, you hardly have any time to discuss the management plan. So you will lose marks on it. So this is something which you should be practicing every day. Every day, even if you don't have a station, you should practice speaking the lines of the history. Hello, good morning. I am Dr. Pooja. I am the registrar in the clinic today. May I check your name and age, please? How would you like me to address you? I understand I have got a letter from your GP, and I understand that you are having heavy menstrual bleeding. Can you tell me more about it? I would like to ask you a few questions. I may need to examine you and get some investigations done, and then we will discuss your management plan together. In the end, I will give you some written information, and I'll write back to your GP. Then history of presenting complete, then obstetric history. Have you been pregnant before? Can you tell me more about the pregnancies? Gynae history. including menstrual history, contraception, cervical smear, medical history, surgical history, drug allergies, family history, social history, including occupational, partner, social circumstances, any history of any smoking, alcohol or drug addiction, and you have to modify history according to the situation. That goes without saying. Now, history of presenting complaint is, now these things you have already done in all your postgraduate and undergraduate. It's the same thing. So when you have the history of presenting complaints, as we discussed in the previous slide, was that it has to be a combination of open and closed questions. You start with the open question, like, can you tell me more about your problem? And then she'll say, okay, yeah, I have been having bleeding for last 6 months and it has increased and I keep bleeding for 10 days and it only stops when I take medication and all that. So then you ask further, okay, how was your previous cycles? Did you have any bleeding in between the periods? Did you have any bleeding after sex? And then if you want to ask about bleeding disorders, all that stuff. So, or have you taken any medication? So all this comes on the history of presenting illness. And then, especially in the gynae problems like incontinence or heavy menstrual bleeding or endometriosis or pelvic inflammatory disease or chronic pelvic pain, you have to ask them, how is it affecting your life? So you can see that I can see that you are suffering from this problem, and you have to ascertain how is it affecting their life. So what is the effect on their what is the effect on their day-to-day life, on their occupation, on their interpersonal relationships because of that problem. So that you have to ascertain. That is the important part, especially in gynae complaints. Now, when you are, this is something I have to repeat all the time, is if it's an obstetric case and a term pregnancy comes to you, maybe the term pregnancy comes with the labor pain or a premature rupture of membranes, and you ask about the history of presenting complaint, don't forget to ask the usual things you ask from any patient who's near term or in the third trimester. Are you having any pain in the tummy? If it's a PROM or any patient who has come in the third trimester, suppose she has come to discuss her mode of delivery, still you need to ask her if you have any pain in the tummy or in the back, are you or if you have any watery discharge from below, or you have any bleeding from below, or any or are you perceiving normal fetal movements, now baby's movements? So are you feeling the normal baby's movement? So these are all things you ask from any case who has come to you near term. Even if she has come to discuss vaginal birth after cesarean, she may already be in labor for you know. So this is a basic thing you should not forget. This is something which you ask from your patients usually, but somehow in the exam situation, we tend to forget the very basic things. Now coming to the obstetric history. So if it's an obstetric case, the obstetric history comes first. As a gynae case, the gynae history comes first and then the obstetric history. Obstetric history, say, have you been, simple ask, don't ask, okay, how many children you have and this thing. If it's not given to you, ask how many weeks pregnant you are, and then ask about the obstetric history of this, history of the present pregnancy. Was it a planned pregnancy? How has the pregnancy been till now? Any problems till now? Have you got your blood test done, the ultrasound done, and what was the report that you have to ask? Have everything been okay? Early pregnancy, ask about folic acid intake. Past obstetric history, you have to ask, have you been pregnant before? Can you tell me more about it, about the pregnancies? Then she can tell everything. Okay, I had first pregnancy was 5 years back and it was a vaginal delivery and I have a child who's 5 years old, like that. If there has been any miscarriages, whether they happened on their own or was it induced, and what was it for personal reasons, okay, or social reasons. And if you are asking any sensitive questions, just say, okay, signpost the patient and then ask. And in infertility case, you ask if any pregnancy earlier. I mean to say, if she has, you have to ascertain when the even if she doesn't have has been with this partner for 5 years and not got pregnant till now, she may have pregnancy children from the previous pregnancy, previous relationship, or the partner may have children. That is very important to ascertain when you are talking about the artificial reproductive techniques, which will decide the funding. If there is already a child from a of that woman or her partner from the previous relationship, so the funding is not received. So that is important. Gynae history, as I told, so it's a menstrual problem that you will ask in the presenting illness, but otherwise you should know the menstrual history, what contraception is the patient using, last menstrual period, cervical smears, whether they're up to date, whether normal. If she has not done the smear, then you should mention that I'll write back to your GP so that it is done at the earliest if it is indicated. Specific histories, like I told you, intermenstrual, postcoital bleeding, urinary incontinence will depend on the case. Medical history, so are you on any kind of medication from your GP now or earlier? If yes, if there's a medical problem, talk about how's the control, last visit to the physician, any admission for the same. So you have to ascertain the severity and if it is going to affect the current situation she is in. Then surgical history, any operation down in the tummy or down below. We are not much bothered about the operations on the tooth or the neck. We are mainly concerned about any scar down. Any specific history, like if you have to prescribe a contraception, you ask about DVT or pulmonary embolism. So have you ever had any clot in your leg or the lungs, or any family history of the same? This way. If the patient was on some medicine before pregnancy and she has stopped on her own, then you ask, I'm not trying to be judgmental, but can you tell me the reason why did you stop this medication? And then she will tell you. Sometimes you may have to talk about blood when the patient requires blood transfusion. You may have to ascertain whether they are Jehovah's Witnesses. So you say that, would you accept blood transfusion if required? If she says no, then you have to tell them, okay, so to explain that, the consequences, and then they have to sign an advance directive for the same. So that is important. And again, family history of, do you have any history in the family which you would like me to know about? In certain cases, you can ask specific histories, like if you're suspecting cancer, you can ask the history of malignancy in the family members. Social histories, what do you do for a living? And it's a gynecology problem, how it is affecting her work. Ask about BMI. Do you have adequate support at home? Is everything okay at home? Okay. I would like to ask you certain personal questions. They might sound intrusive, but I ask them from all the patients. Do you smoke or take alcohol or any recreational drugs? If she says yes, how many cigarettes smoking per day? Have you thought about quitting smoking? Are you aware of the harmful effects of smoking in the pregnancy? All these things. Similarly for alcohol and drug abuse. And talk about allergies, history of drug allergy, which I told you very important, blood group, BMI, also you should remember. And modify it according to the situation. And in the end, you will say that, okay, I will write back to your GP about your care plan. I'm going to give you certain written information in the form of patient information leaflet. And if you can name the leaflet, it is well and good. Suppose your patient has endometriosis, say that I'm going to give you a patient information leaflet on endometriosis, and so on. And then you close the session by saying that I'll fix an appointment with the consultant. And if you want to discuss with your partner, we can fix another appointment with the same, and so on. Okay. So these are the closing comments. In between, you can just ask them, once you have taken the full history, you say that anything we would like me to know, anything else you would like me to know, anything you would like to add, and she may give you extra information. And examination, as I told you, I would like to examine you because, and give the justification. The test also, again, you have to justify, discuss the care plan, and you should tell about these things. You would be under consultant-led care, or it will be a shared care between the consultant and midwife, regular visits, or if you want to give, refer her to a multidisciplinary team, you say, I will refer you to a multidisciplinary team, which would include a gynecologist specialized in urinary problems, incontinence midwife, and nurse, and all this stuff. Okay, if you agree, I would like to refer you to a mental health specialist, perinatal mental health specialist, and all that. If it's a cancer case, you tell about there'll be a cancer specialist nurse who would be, who would be looking after your care and coordinate the treatment plan between the multidisciplinary team and you. All that thing. So you have to say whatever is justified in the situation. Now there are certain tricky scenarios which we will be emphasizing upon. These are important things, especially these stations we like to discuss, and you should be practicing. Hidden agendas like domestic abuse, bullying, this will come in a teaching station, angry patient or relative, complaints, complication in surgeries, breaking bad news. Again, difficult, not as far as the theoretical aspect is concerned, but the communication aspect, dealing with young adults, HCFPA guidelines, abortion guidelines, which means that you need to know the legal aspects of things happening in the UK. Courses, again, very confusing questions. How many courses to do? Which course to do? So the best way is to talk to your peers, talk to your colleagues who have already passed the exam, other friends, and take feedback about the courses and decide. It is a good idea to do an online course earlier so that your preparation is smooth and sustained. And then later on, when you go to the venue, especially in London, you will have many on-site courses, which will be circuit courses. So that is when you're well prepared with most of the aspects of the exam, and then you take the course so that you can fine-tune your preparation. If you get the RCOG course, nothing like it. Difficult to get because so many people will apply for it. Again, it's first come, first serve, and those places get filled very quickly. But preferably, if you get an RCOG course, you should be doing that. I'm talking about that which happens before the exam. And if not, then there are many non-RCOG courses which are also good. And you can decide on it after talking to your friends. Okay, now we will be doing 2 stations. I'll just take a break of 1 minute and I'll be back. So whoever wants to present the station, please write it on the chat. Whoever wants to present, volunteers. There are 2 stations to be done now. Just give me 1 minute. So somebody has volunteered, but I can't read your name. Who's it? There's no name.
It's Dr. Ghazala.
Hi, Ghazala. How are you doing?
I'm fine.
So you are preparing for November?
Yeah, Chana.
Okay, so we'll do the station with you. Just give me a moment. I'll fix a timer for you. Okay. Okay, so your 2 minutes start now. Okay. Okay, your time starts now. 10 minutes. Ghazala?
Yes, 1 minute, Dr. Pooja. Yeah. Hello, I am Dr. Ghazala, one of the gynae doctor in the clinic today. Can I check your name and age, please?
Hi, doctor. I'm Brenda. I'm 16.
Nice to meet you, Brenda. How would you like to be called?
You can call me Brenda.
Okay, Brenda, you can call me Ghazala. Brenda, I can understand that you have been referred by a GP that you have a large labia. So, is that okay? Is that right?
Yes, doctor. So actually, I was just looking at myself, down below, and I felt that labia. I read about it. I think it is quite big, and I need a surgery for that.
Okay, Brenda. And we will address your. I will address your concern. But before that, can I ask you a few questions, and then I may need to examine you in presence of chaperone, and then I may need some investigation, and then I will explain to you about your management option. Is that okay with you?
Yeah, doctor, it's all okay, but I know I need surgery. But please go on.
Okay, Brenda, I understand your concern. Brenda, can you tell me more about that? Since how long you are sexually active?
I'm not sexually active, doctor.
Okay. And Brenda, excuse me, Dr. Pooja, 1 minute on. So Brenda, tell me more about that. Why you think so that you have an abnormal labia?
So doctor, as I told you, I was looking at myself, I keep checking whether everything is okay. And then I went on the internet, and when I saw those images, I think my body is absolutely abnormal, and uh, I couldn't talk to it with anyone. And I have become very conscious, and I used to run a lot. I stopped that, and I'm very anxious about it, doctor. It's affecting me.
Okay, Brenda, thank you for sharing your information, and whatever you will share with me, it will be confidential. So Brenda, tell me more about your menstrual history. Do you started your periods?
Yeah, I started around maybe 2 years back, doctor. My periods are all okay.
That's good. And Brenda, do you have any medical history of concern for which you are taking medication?
No, doctor, nothing.
Okay. And do you um, do you have any allergies?
No, doctor, not that I know of.
Do you have done any surgeries in the past?
No, nothing, doctor.
Okay. And Brenda, you have any family history of concern?
Mm, no, I can't think of anything right now.
Okay, that's fine. And Brenda, what do you do for living?
Uh, I'm a student, doctor. I'm in grade 11.
Okay. And how are things at school?
Yeah, everything is okay. But as I told you, I was very active in sports. But because of this problem, I've just stopped that because I've become very conscious. Rest, everything is okay.
Okay. Brenda, and with whom do you live? How are things at
Uh,
home?
I live with my mother and my younger brother.
Mm-hmm.
My father and my mother are separated. Everything is okay. My mom is very good, and she's very supportive. She's fine.
So Brenda, do you feel low in the past 4 weeks, or do you feel lack of interest in the surroundings?
No, doctor, nothing like that.
Okay. And a few routine question, Brenda, I ask for my every patient. Do you smoke?
No, doctor.
Drink alcohol
No, doctor.
or any recreational drug?
No, never, doctor.
Okay. So Brenda, I may need to examine you in the presence of chaperone to see your blood pressure and about your BMI. How do you know about your BMI?
No, doctor. But I think the GP said it was normal. I
Okay.
don't remember how much was it, but he said it was okay.
Okay. And Brenda, I would like to examine you from down below as you are concerned to see how's your labia.
Yes, doctor. Because I require that surgery. I want it to be okay.
Okay. And then let me explain to you, Brenda, the UK law actually. Do you heard about anything about female genital mutilation?
No.
Okay. So actually, Brenda, in the UK, the cutting down on the female genitalia is not allowed, and any person who is involved in this, um, it's uh, it's taken as a crime, and it's not allowed for her personnel to do that. But if it's really for some person, it's really affecting the quality of life, or if it's really affecting her. So first of all, maybe I need to examine that one, and if it's still it's really so, then I may need to involve my consultant opinion, and then we can discuss on that. Is that okay with you?
No, doctor, but it's really affecting me. I need to do it.
Okay, Brenda, as I told you that we need to examine that, and we need to um, discuss with our my consultant. And because you know, Brenda, the labias, because for some ladies it can be just normal, and if we do a surgery, so these surgeries can have some complications in the future life for the lady. And
What complications?
yeah, because what do you think that, because if someone has abnormal labia, what can, because it's can be just physiological, and but if we cut on that these labias, the scar tissue can have then later on you can have difficulty in the coitus, and maybe there can be difficulty in urination on the recurrent urinary tract infections, and also difficulty in the coitus,
What is coitus, doctor?
and difficulty in the sex.
But I think but I saw it on the internet, doctor, all the images, it's absolutely different from them.
Mm-hmm.
You know, I saw pictures on the internet, and my labia doesn't look anything like them. So that is why I'm telling you it's abnormal. Even the GP also examined, and he's had a look, and he said it looks normal, but I don't think it's normal, doctor. And it's affecting me, so I can't. I've left my sports, and you know, I'm having difficulty. I may, you know, I don't feel like meeting my friends.
Okay. And what about your feeling about your body if compared to your friends?
I just want this thing to be treated surgically. I want a surgery.
Okay, Brenda, your concern is valid. We have very nice counselors, and you can talk about on that. Maybe they will help you in talking to some counselor. They are very expert people, and they can help you, because as you told, that GP told that in his view that your labias are normal, and you are thinking that you have an abnormal labia. So talking to a counselor always help. If you want, I can we can
Okay,
take.
time is up. Okay, I gave you some extra time, but it's up. Okay, Ghazala. So what's your feedback on yourself?
I don't know, very bad.
I have put a very difficult case for this because sometimes in the exam also you'll be stumped by a new kind of thing. It's not a new case, but something different, which is not the usual, and you are stuck. And it's basically, this station is all about negotiation with the patient. So were you able to negotiate with this patient? It's a difficult patient.
Yeah, because I was not getting it, like she have some psychological problem, what that she is just thinking like that, and I don't know, really I couldn't get it.
No, but is she talking about female genital mutilation?
I don't think so. This is not female genital mutilation. This is just talking about labioplasty she want.
But why did you talk about female genital mutilation? If she wants surgery, will it come in female genital mutilation?
I think it's a part of it.
How?
But I know
What is
that
female genital?
radioplasty can be done if it is psychologically affecting the patient, if it's really large or something like that.
But is it female genital mutilation? If it is done by a surgeon, it's a plastic surgeon or a surgeon in a hospital setup, would you call it the female genital mutilation? Because you specifically said it's UK law and all. Will it come under female genital mutilation is my question, because it completely changes your case.
No, I don't think so. It will not.
It should not. It is not. So basically, it might not be indicated in this case because it's mostly psychological. You are right, but it is. I would not put it under female genital mutilation. Is the first thing. Okay, so let us discuss it. It is difficult. I give you that. It's a difficult case. You have attempted it. This is a session for the November exam. I know most of the people have not started preparation at this point of time. So it is a good effort, keeping into mind all these things, and you volunteered for it. So I think it's quite good. Now, when you enter this station, suppose now I have given you this, let us see how we approach the station, because what I want to teach or to talk about is how to approach any station, because something new may be thrown at you. So how do you approach it? So now let us go back. I have projected this on your slide. Okay, you in those first 2 minutes. What do you note in this case? What are the points which come to your mind in those 2 minutes? So suppose now, what would you write on your notepad?
Yeah, for me, what I have written that she is a teenage girl, and especially in this case, I have to exclude the domestic violence and the depression, and her presenting complaint and what she.
But okay, so did you rule out domestic violence or abuse? Did you do that?
I asked about this one, the support, and about depression. I tried to ask her, and she was not sexually active.
Yeah, but I don't think you gave any question pertaining to abuse. It can be sexual abuse. It can be, even if she is not sexually active. The question you asked her was, "How long have you been sexually active?" And actually, she told you, "I'm not sexually active." But you didn't ask about abuse. So no role player is going to give you the answer as abuse if you ask this question, frankly speaking. Okay, that is a good thing you wrote, but you didn't ask it properly. Next, what else did you write?
Yeah, I wrote already that if she is sexually active, I have to tell about contraception, safe sex practice, and chlamydia screening and gum clinic.
Very good. Right. That's right. That's fine. Yeah. Okay.
Domain safety tests and this one, the information gathering and this clinical knowledge as what are the domains tested, and then I just write counselor support and consultant involvement. Actually, I could not get the proper idea. Maybe like
see, you did. I must say you did tell about the points. So counseling was fine. Consultant opinion is fine, because she is not agreeing to you. You have to again shift it. She did not agree to you till the end. One thing. You said coitus, so medical jargon you should avoid, and that's why I asked you the question, what is that? You said physiological, again, patient might not understand. FGM, I would not label it as FGM at all. You asked about smoking and alcohol. As I told you earlier in this, you should signpost it. That not only that it is a routine question, you say that I'm going to ask you certain personal questions, and they might seem intrusive, but I ask them from all the patients. So just signpost. If she's a young girl and you're talking about recreational drugs and alcohol and smoking, you have to be more sensitive in that. You did talk about confidentiality, which was good. You said, as I said, since how long have you been sexually active? You should not assume that she's sexually active. You should ask her. Again, you should signpost. I'm going to ask you a personal question, and it might seem embarrassing to you, but are you sexually active? Ask like that, rather than assuming that she would be sexually active because she's coming with the labia. She has just told you, I have looked at my body and I think it is abnormal because I've compared it to the internet. This is what she told you. So you should not assume anything, ask the patient, okay? In a young, so it's right, when you go into this station, what you will note is that she is a 16-year-old, so it's a young adult, and issues are confidentiality in any young adult in any kind of station. So we will do later things about emergency contraception or contraceptive planning or termination of pregnancy. So young adults may come with any of these issues. The same things will go for all these cases. One is the confidentiality, okay? Assessing the actual concern of the patient. Ruling out sexual abuse is the most important, because you have to think about safeguarding in these cases. Social circumstances, which you did ask, but again, I thought it was again haphazard. The history was a little haphazard. It took a long time for that history. Social circumstances at home, as you said, you did ask about how she's doing at school, who stays with her. But again, I thought it was a little haphazard. And then you rightly said if they are sexually active, talk about contraception, talk about the sexually transmitted diseases, screening, about safe sex practices, use of condoms in all these cases. Whatever they may have come with, they may come with termination of pregnancy or emergency contraception, but it's your duty to inform them about these things. Okay, now this case, though that findings are not given to you, mostly she's normal basically. It's basically a self-image kind of a issue. But the explanation, what you need to explain it, because she constantly, what I said earlier was, you have to listen to what the role player says and respond to that. She has been telling you 3-4 times, she told you the same thing. I've seen images on the internet, and then I think my labia is abnormal. So again, I'll give you, and I will ask you again this question. So how would you respond to that? So she's again and again, 3 times she tells you, I have seen images on the internet and my labia doesn't seem anything like that. So how do you respond to this? You know her labia is normal. Now, what do you say to her?
To what extent do you think that they are normal, or what abnormality do you think?
Okay. Anything else? Okay. So just let me tell you what lines can you see. This is just negotiable. There's nothing to be done in this case. You have to actually tell her that surgery is not advisable for her. And anyways, you are not going to plan surgery at this age for her. That is basically the gist of this station. But the thing is that you negotiate with the patient and try to make her understand that this is something which is normal, and it's a normal variation of the anatomy, and surgery will cause her more harm than good. This is what we are trying to, isn't it? This is what we are trying to explain. Now, how do we explain it to her is the question. So I have discussed what are the points you will take into consideration. So in the history, it's important to rule out. So you can just ask, has anybody come with you in the beginning? When it's a young adult coming in, you can ask them. Then important to you ask about sexual activity. You should be very sensitive about asking it, but you do need to ask whether she has a boyfriend, she's sexually active, all these things. You should ask about her, and then you ask her, what do you do for a living? So you can just, you don't expect her to be doing, so you can just ask, are you in school, are you studying? If she says no, then are you working is okay, but I would not go to the question straight away that what do you do for a living in this case. And then the social situation, who lives with you, and whether there is adequate, like who looks after you. So you can say that, okay, she said the mother is mother is very supportive, it's fine. So the social situation in her home and in her school, both has to ascertain. At any point of time she has had, she was supposed to have sexual abuse or physical relationships against her will, is something we should always rule out now or in childhood. So it may have occurred in childhood and has the psychological repercussions right now. So this is what we rule out in these cases, which is important. If everything is fine, all the history is negative.
Yeah.
Pardon?
How should we try to evaluate?
So again, again you say signposting you have to do. You say that I'm again sorry to ask you this, and it's is embarrassing question, but I am worried about your safety, or I am worried. I need to ask these questions to ensure your safety. So I want to know this. This will again be valid for emergency contraception or termination of pregnancy. So that at any point of time you have been forced to have sexual intercourse against your will, now or earlier, at any point of time. You just ask her. You have to be frank. You have to signpost that I know it's a sensitive question. It's an intrusive question to ask, but I need to ask this as I'm concerned about the safety. Especially when it is termination of pregnancy or emergency contraception, especially if they say, okay, she has a sex with an unknown person, and all the more reason. And it may be childhood. So because this is more psychological, so it may be childhood abuse, which is now presenting as her having some body image problem. Okay, so you have to signpost, but you have to ask. There is no other way to ask it. So when she says, okay, so you say it's, even if it's normal, you say that it is common for girls of your age to feel conscious about their appearance. Okay, and there is a lot of variation. Now, then she says about the internet and all, they say that there is a lot of variation in the appearance of labia, and none of them is abnormal. So you say that the labia comes in different shapes and sizes, and but you have to, the other thing you have to ask in this case is, she keeps on saying that it is abnormal, it is large. So you have to ask her whether it is causing her a physical problem, whether it is causing any irritation or discomfort during any physical. So she says, I stopped running. So you have to ask her whether actually you were having any problem in running because of this, or she is just because she's concerned about how it is appearing, she has stopped her sporting activity. Has she any problem in wearing tight underwear, tight clothes? That is what you have to basically ask, whether it is actually causing any physical discomfort. This is what you have to ask. Okay, so this will rule out any actual abnormality, which is like, suppose she is having large and she's having discomfort in wearing her when she's running, wearing her costume or all, then it shows that it has some physical problem attached to it. If she says no, so it is interfering in her daily activity, is what we need to know. What she has told you till now is that, okay, it's I feel it is abnormal, I am becoming very conscious about it. She has not told you that I am having any problem directly due to it. So that you have to ascertain what is the difference. So you say that when she talks to you, about internet, so you say that, so I know that you have seen many images of the labia on the internet or online. But I must tell you that social media or the internet does not always show the true picture. Most of these images are retouched, and these are the real appearance of a very few women. Okay, so they may show, sometimes they distort the images and show it. So you should not blindly follow the internet. So you show that I will show you a picture or chart of with different types of labia, which are different shapes, color and size of labia in different women, which are all normal variations. So there is actually they have a great wall of vagina, which they have different pictures of different types of vagina. So they say that I'm going to show you, and you can see that there is a great deal of differences in the appearance of the labia from one woman to the another, but they are all normal. So you have to basically emphasize that it may be different from what she has seen, but that is not the true picture, one. Secondly, there is a lot of variation, which is all part of normal. So this basically has to be told. Okay. Also, you tell us that you are just 16 years old and your body is in a state of transition. So still a lot of growth is going on, and finally the appearance, it's about after 19 years of age is when this growth will stop, and then the final appearance will be there. Then when she says about surgery, then you say that the surgery, right now, the surgery can do more harm than good, because again, your body is growing. So if we do any kind of intervention or invasive procedure now, it can alter the natural growth of the tissue or the body, and it can cause some harmful effects like complications of surgery, urinary problems, and sometimes it can also lead to injury to the nerves, and it can cause difficulties in having sex later on. Okay, so this is one thing you should tell. So you should not be entirely dismissive. It should not be like, okay, you are wrong and I am right, but it should be, yes, I know you are concerned, but this happens with many girls. So you have to say, okay, yeah, it is something natural to have these concerns. So then you say that, okay, sometimes because of the availability of these images on the internet, many girls feel this anxiety. I would like to, if you agree, I would like to ask you to meet a counselor who would discuss, who will be able to explain you what you are feeling, and it will help you to deal with this anxiety in a better manner. Okay, this is one thing. You obviously you did offer an examination, that is good, and you say that, okay, I will take a. If she's very again emphasizing on the no, I want to say that I will always also in the meantime you meet should meet the counselor, and I will always also fix an appointment with the consultant. Also, you can ask her about, like, she said her mother is very supportive. So you ask her whether, has she talked about this with her mother? Would she like to have another meeting with her mother so that she can explain, we can explain it to her also. Also, you tell her that this is normally not allowed before, should not be, according to there is a basically British Society for Pediatric and Adolescent Gynecology, which is the British Pact. So they recommend, you can tell her they recommend that the surgery should not be performed before the age of, under the age of 18 years, okay? Because you told that, okay, it develops till 19 years of age. Also, this has not been supported by the NHS. So there's no funding for this kind of surgery. So this has to be paid. So all these things you can, at different points of time, you can explain. So main thing to explain to her is that it is a normal variation. It is okay to have this anxiety. Many girls have this anxiety, and it's fine if you have the anxiety. So, you can meet a counselor, and then there are complications to the surgery if it takes place. And anyways, the surgery is not allowed below 18 years of age. So this is how you would explain. Okay. And yes, as she's a young adult, rule out other things like sexual abuse, and if she is sexually active, definitely, as you said correctly, contraception, sexually transmitted diseases screening, and safe sex practices, which is condom. This is for all young adults. Make sense? Can you feel a little better after what I have told you?
Thank you so much, Dr. Pooja.
So the best thing is to actually, this case is there in the, similar cases there in the book of the Oxford Text's book. So the best way to study is that tomorrow you should write down the whole template. This template you should write down, because you will not remember it till November. So write down and understand what points you are going to say and how you are going to say it, because you have to be more sensitive, because it's a young girl who is coming. She may not open to you unless you are very sensitive with her. So, and then write down and then record it, and then listen to yourself how you are performing in this. Okay, it is difficult, I know, but I keep this difficult case in the introduction session so that you actually get used to it. Now, since you have presented it, you will feel much better if you have to do it next time, definitely.
Yeah, thank you so much, Dr.
Okay, thank you, Ghazala. So next case, I did not see any volunteer. I have a structured discussion now, which is an easy one. So don't get scared, and you can volunteer for it. Please volunteer fast so that I can finish this meeting in time. We have 45 people here. I need one volunteer for the next case. Deepa has asked, in case it is really abnormal length of labia, since we don't know, there's no cutoff for the length of labia, but yes, if it's affecting her day-to-day activity, then again you do refer her to a counselor, fix a meeting with consultant. But anyways, you will still not advise surgery at the age of 16 years. You would allow the normal growth to occur, and then, but yes, you have another meeting with the consultant and do send her to the counselor, because again she is anxious about it. So if there is no volunteer, I will move forward because there has to be somebody to present for me to discuss the case. Anyone? I'm just waiting for 30 more seconds, because again, otherwise I'll go forward. I'll just, okay, Dr. Najla? Najla.
Yes, Najla.
Hello. Hi, Najla.
Yes,
how are you?
How are you? I will try.
I'm good. I'm tired of speaking, so I want somebody else to speak now. Okay, so let us just put the timer for you. It's okay. It's okay. If you don't do very well here in this session, it's fine. At least you try and you start speaking. That is the main idea behind it, so that you get an idea what's going to happen later. Okay, so your 2 minutes start now. Okay, okay. So I gave you a few extra seconds. I was busy. Fine. Okay, doctor, have you read the scenario?
Okay.
So your first question is, what would be your immediate action?
Okay, doctor. My immediate action, this is an obstetric emergency. I will call for help. Help will be for another colleague, a senior one, for the anesthetist, for the porter, for conducting the blood bank, and more staff. Where is the question?
Okay. After immediate act. So what? This is your immediate. You finished?
No, I will call for help. I will try to see if the patient having no IV lines. I will ask to put 2 wide bore cannulae for the patients and giving her oxygen, starting IV fluids and taking blood for the blood grouping and cross matching. I'm preparing for unit at least of blood, and I will try to massage the uterus at that time. From the case, seems to be injury. I need to explore at that time. I don't know the limit of the question where I will stop.
That you can't speak in the exam. You stop,
Yeah.
I will ask the next one. Okay. After immediate action, how would you manage the hemorrhage?
Okay. Treatment of postpartum hemorrhage is 4 T's. The first one is atony, and from the case scenario, seems to be for sepsis delivery. Seems to be it is maybe it is the injury to the cervix. I need to explore the patient with good light, with good assistance, with anesthesia in the most likely in the operating theater. This will be after managing atonia by giving the hypertonic drugs in a form of oxytocin, misergine if the patient having no contraindication for that, and I may use also misoprostol or carbopros, prostaglandin F2 alpha if our history allowing me for doing so, because it is contraindicated in asthmatic patient. So after that, I will explore, as I said, if there is any injury, we need to suture. From the investigation, I think that the patient, if having any bleeding coagulation problem, I will try to involve the hematologist and correct that. And also this patient having a previous cesarean section, also I may put in my mind that the patient may have uterine rupture. I may need, if the bleeding is not stopped by all these measures, I may need to going for a laparotomy. I need to inform the anesthetist about that. Starting if the blood had been prepared for the patient, I will give the blood for the patient and starting doing exploration. By doing laparotomy to see if the patient having uterine rupture, she may need even. I will go through all the measures that I will do, start repairing. If no, I may need to go involve intervention radiologists. If I may need to do internal iliac artery ligation, even I may need to do hysterectomy.
Okay. What would be the surgical management if the medical methods fail?
So the surgical management, I might start by putting the uterine like Bakri balloon or roster or any balloon or tamponade, uterine tamponade. If it did not stopping the bleeding, I may need to do any like what I want to say, the any type of the bracing sutures, or as I said, I may do devascularization of uterine artery or internal iliac artery ligation. I may involve vascular surgeon in this, or my consultant can do, or we can do also hysterectomy. If we are in a setting involving intervention radiologist, we can call him, or no, we can proceed for hysterectomy.
Okay. This lady unfortunately did not respond to the medical and conservative surgical management and had to undergo cesarean hysterectomy. What are the clinical governance issues you need to address in this case?
The clinical governance issue, this I need to, as I said before, we already informed the consultant, and we need to to write an incident report, and we need to do I don't know I understand the question or no. We may need to call another consultant so as to take because for a cesarean hysterectomy you need to take another opinion, and you will take if you agree both for this, and the patient is already anesthetized, and we cannot, it is an emergency, we cannot take a consent from in this issue. We will proceed by doing so for her life, and later we will explain to the patient what we do and why we did it, and we will write the incident report and debriefing the patient, and we will we will do as a risk management for that case, and okay, that's what I will say in this point.
Okay, fine. Anything else you want to add? Okay, no problem. So you still have 2.5 minutes left. And this happens, this will happen in many structured discussions. So you will find that when you are doing the simulated patient task, the time is very less. But when you're doing a structured discussion, you might finish it early. And in the exam, sometimes you're sitting in front of the examiner. You cannot leave the cubicle, and just you are facing the examiner and nobody's speaking. And this happens quite often. This is because you said it correctly. You will not know till what level you have to speak, because you don't know what's the question coming next. And this happens, but it is okay. As far as your answers are structured well, it is okay. You may have to repeat the answer again if you have already said the same things in the previous question, but it's fine. You will have to repeat it. I will suggest that you speak a little slowly. I think you were going quite fast, and it was sometimes difficult to catch you. Like in between, you were speaking very fast, and see you have even time left. So try to slow down a little bit. Practice that when you are speaking. Especially in these structured discussions, you need to slow down. Sometimes when you're talking to a role player, they may not understand what you're saying, and then it wastes time. So try a little bit slowly. I know it was simple in the sense you know the clinical knowledge wise you spoke most of the things. It's very clean cut, straightforward postpartum hemorrhage. Just let us look at this question. It was right in the beginning. You said very nicely that it's an obstetric emergency. So it's a good thing. So sometimes, what the candidates tend to do is that they start reading from the question. So please don't read the question. Whatever question, whatever situation is given to you in a structured discussion is for you to interpret outside. You can see in this question, you can see it's a multiparous lady. She has an instrumental delivery. She has a previous cesarean. So she has multiple risk factors for PPH, both traumatic as well as atonic PPH. So it may be either of the two cases, and the management will depend on what is the cause of the postpartum hemorrhage. So it's fine. You say that it's a, so I've been called, okay. So I've been called by the midwife to see the patient, Ms. Serene Smith, who is a 34-year para 4, previous cesarean with an instrumental delivery and postpartum hemorrhage, which is an obstet, and she is an obstetric emergency. So immediate actions, you rightly said, call for help and tell. The important thing is that you say that, okay, since this is an obstetric emergency, I would like to call for help. And who would you like to call for help? Explain in the next sentences. So I would like to call an experienced midwife, either a labor ward coordinator or midwife in charge. I would like to call a middle grade obstetric person, another obstetrician, and alert the consultant, an anesthetic middle grade, and alert the consultant. I would like to also alert the blood transfusion laboratory so that which you may require blood and blood products. Hematologist on call is again alerted. Porters for specimens of blood, specimens and blood. A pediatrician to look after the baby, and a scribe, a person who will note down the events, any obstetric emergencies, shoulder dystocia, postpartum hemorrhage. There has to be some person who will write down the timings, okay, who was called, when, who comes when, what actions were taken at what time. So that is because the other people are involved in the management of the patient, so they won't be able to note it down. So one person has to be there to note down all things and alert the OT staff as well, because she might require a surgical intervention. So when you say call for help, you should know whom you are calling for help. So there are like a list of people you will call for help in this case. Then the other actions which you are doing on the patient. So one is the resuscitation of the patient, and then initially you should ascertain. So in the immediate actions, I would say 1, call for help, 2, resuscitation of the patient. That means oxygen, IV, 2 14-gauge IV lines, keeping the patient warm, giving her a left lateral tilt, start crystalloids, 2 liters of Hartmann solution, 1.5 colloids, and take a sample for blood, for a full blood count, cross-match 4 units of blood, send for investigations like blood urea, electrolytes, liver function tests, coagulation profile, say all these things. Arrange for blood and blood products like the fresh frozen plasma, platelet concentrated cryoprecipitate, so that you say that, okay, this is your immediate action. And so it's not that you are going to do everything. You will say that I will ask someone to start an IV line, start this, and I would like to ascertain the cause of the hemorrhage. For that, you have to do an examination of the patient. See, one person will check the pulse, BP, okay? Then you should have a look at the tummy and do a vaginal examination to see whether it is whether the uterus is contracted or not, or if the uterus is contracted and she's bleeding, then more likely to be a traumatic PPH. So this immediate action is resuscitating the patient because she's already lost a lot of blood, she's dizzy, she's undergoing a postpartum hemorrhage. Call for help, resuscitation of the patient, and ascertaining the cause of the PPH. That would be my immediate action. This is basically what you have to think. So the structure discussion means you have to structure the answer in this manner. Okay, next, how would you manage the hemorrhage? This is after the immediate action. So you have at least, you started the fluid, you have arranged for blood, everything is, and you have sent the investigations. Now the management of hemorrhage, you say that the management of hemorrhage will depend on the cause. If it is a atonic hemorrhage, I will start her on medical management. Then you say all these things, what I would like to continuously do a uterine massage and then ask somebody to give. So you cannot do all the things in PPH. You will be with the patient and somebody else, the midwife or another obstetrician will be, giving all the medication. So you start with, you talk about oxytocin, you talk about, and one important thing is Foley catheter. Okay, you have to put a Foley catheter. One is, if there is atonicity, it will, if the bladder is full, the atonicity will, it will be further there. Okay, I will decide. Okay, I am also speaking very fast, so sorry, I will be slow. So you catheterize the patient so that if the bladder is full, that takes care of that. So that will help in contracting the uterus. And somebody is to be there to continuously monitor the pulse, BP, respiratory rate, pulse oximeter should be there. Okay, I would like to continue with the uterine massage. So that is to rub the uterine fundus to stimulate the uterine contraction. So you give oxytocin, 5 units slow IV, then you repeat, then you give methadone or ergometrine, which is 0.5 mg slow IV or IM. Then oxytocin 40 units in a drip, which is 500 ml at 125 ml per hour. Then you talk about prostadine or carboprost, tromethamine, 250 microgram intramuscular every 15 minutes. Up to 8 doses is the maximum dose. So you talk about these things, and you should remember, even in part 3, you may not remember doses of each and everything, but some things like emergencies, like eclampsia or PPH, all these doses you should remember. There is no way they would excuse not remembering these kind of dosages. So I would make a note of these important dosages, like all the obstetric emergencies, what dose of what drug you would like to give, like PID, all these things, or even hypertension in pregnancy, how much dose of what medication you give. Make a note of it separately. Please revise that before going for the exam. And they say if the atonic PPH continues even after you've given the third dose of carboprost, you need to shift the patient to the operation theater. And you can talk about the somatic PPH. So if the uterus is well contracted, I will try to find the cause of the trauma. It's an instrumental delivery. It's a previous cesarean. The various causes can be a cervical tear, vaginal tear, or it can be a uterine rupture. And then depending on that, the management will be there. So suppose it is an atonic PPH and the medical management fails. You told about most of the things. First is the intrauterine. There you talk about intrauterine balloon tamponade, hemostatic sutures, stepwise devascularization, internal iliac artery ligation if available, or selective arterial occlusion if there is a interventional radiology set up there, or a hysterectomy, which you rightly said. 2 experienced clinicians have to take a call on a cesarean hysterectomy, especially if in any case there's an accreta or a increte placenta. This question is what you didn't explain very well, is the clinical governance issues. We should remember that clinical governance is something which we overseas people who are not in UK are not very used to. So this is something which we have to deliberately practice in all the cases scenarios, is the clinical governance. So now this case, you can say it is a massive PPH, and now the patient has had a cesarean hysterectomy for that. So that means, obviously you said correctly, incident report has to be filed in this case. So any case of postpartum hemorrhage more than 1,500 ml has to go as an incident report. Any PPH resulting in a cesarean hysterectomy will go for an incident report. This is one aspect of it. So yes, a risk management team has to be set up, which will have a risk manager, and it will have members from the obstetric staff, from the nursing staff, and the OT staff, okay, and maybe under the consultant. The risk management team is going to look into the case, okay, whether the right actions were taken. There has to be a risk assessment of whether she, at that point of time, whether the instrumental delivery was indicated or she should have got a cesarean done at that time, keeping into mind her previous cesarean and multipara state. So all these things have to be taken care of, and the risk management team has to ascertain all the facts of the case and prepare a report. This report has to be discussed in the clinical governance meeting. Talk about these things. Clinical governance meeting. A look has to be made about the protocols in the ward, in the unit, about multiparous patients presenting in labor with or those people or those women or those patients who have multiple risk factors for PPH. Now this patient has multiple risk factors for PPH, the protocols for that, and an audit of all these cases should be done, and if required, a new protocol to be formed and a re-audit should be done. Also, skills and drills training for the obstetric staff as well as nursing staff to manage any case of postpartum hemorrhage has to be done. Skill and drill training is very important because these are emergencies. So they should be able to respond immediately to these emergencies. Debriefing of the patient, as you said correctly, as well as debriefing of the team members. I mean, the nursing staff, the OT staff, the obstetric staff, the debriefing has to be done. Okay, and debriefing of the patient and the relative, as you said. So these are the things we will mention in any kind of a clinical governance. Are you able to hear me well?
Yes.
Yeah, okay. So somebody maybe some problem at their end. So this is basically what I want to emphasize is it is a simple case, but the thing is in the structure discussion is that we need to structure ourselves. That is the main point behind any structure discussion. So yes, Momna, yes, duty of candor in the sense that you have not caused any complications. So I would not directly consider it the duty of candor, but yes, the debriefing of the patient will include the circumstances behind the complication, what happened, and we were not able to control. So, or basically the report of the risk management team, if there is any adverse report, if it is found to be any problem, that will be discussed further. If the patient asks for a complaint, then basically, yeah, you definitely if you are talking to the patient, you will say that I'm sorry for what happened, definitely. But this is a structured discussion, so you're not talking to the patient. So when you're telling the examiner, you say that, okay, I will debrief the patient and the relatives about the circumstances governing the case. And definitely, if the patient wants to find out or file a complaint, I will assess the patient in the procedure. So that is the duty of you are honest about what has happened. You are definitely empathetic with the patient that this has happened. You are sorry for what happened. But basically, the risk management team will will look into the merits of the case and see whether there was any thing which should not have been done, or there was any duty which was not performed, and whether it could be improved. So basically, that is why you do the risk management. You see the case, you find out what was the problem that occurred, and later on, how to change the protocols, how to improve it so that the patient care becomes better. So this is what is risk management. So we will discuss risk management. We'll do the sessions on risk management in the course, and it's a difficult topic, I know, but that's why I added this question in a PPH case, because other things are very straightforward. You know how to manage PPH, but this is something we will all get stuck up in. But if you remember a few words, you can actually do all kinds of risk management. So it was just a prelude. Okay, so let's talk about the course. It's 3 months course, or a little more than 3 months probably. We will have 17 sessions. Now, as I told you, there are going to be 14 sessions specific to each module. So each module will be in one session. Okay. And there is one introductory session, because I have discussed in detail about the preparation, and also the introductory session will be about how exactly you should use that course to the best of your advantage. So you know how you will be reading with us in the course. So as I told in the sorry for this, it's not going one second. So as I told you on Facebook, I've written like we are going to be your study buddies. So together we will formulate a plan or a strategy for the preparation going forward for the November exam. So the first session, I'm going to do the most difficult cases. Difficult cases means there will be the different cases which may not be fitting in each module. Now something like the bridging thromboprophylaxis, or enhanced recovery, or maybe reading of a Muse chart, maternity dashboard. So I have stations on them. They are basically the structured discussions and interpretation of these things. So we'll do it right in the beginning so that you can prepare it well at the end. So these things should not be left till the end. So we start with the most difficult portion. And then weekly sessions, we start with the modules. We have tried to, put the modules, similar modules together. Like if we have management of labor, the next week will be management of deliveries, because they are related and sometimes there is overlap. Antenatal care and maternal medicine, they will come one after the other. So we try to, the sequence of the sessions will be such that similar kind of sessions will be, similar kind of modules will be together. Please mute your mic. Somebody's mic is on. Okay, so the weekly sessions, the advantage is that once you know that this module you have to prepare, you prepare it well in that preceding week. So in the preceding week, you will prepare that module and we will give you topics where the station is going to come. Now, the idea of giving you the topic is because there are two ways to go about it. That one is that we don't give you anything and it's all extempo. But the problem is that this time is much before the exam. So if we give you the topics, you can prepare the topic well and prepare. But the station will not be given, only the topic will be given. So because I tell you that I'm going to give a station on ectopic pregnancy. So it may be a pregnancy of unknown location, it may be a tubal ectopic, it may be a structure discussion or a simulated patient task. So anything, any type of station may come. So even if you have read the topic, it is still difficult to present the station because that's a different thing altogether. That will depend on what kind of situation has been given to you. So then you prepare it. During the session, we will talk about that module first and talk about the template related to that module, what specific history is necessary for that module, what are the different stations which can be possible. Now that is an unlimited list, but still the most important stations from that module. It is practically impossible to discuss all the stations, but if you know the approach, you can actually present any kind of station. And then so templates and how the domains work in a particular module will be told in that session, and then we will do the live stations as we have done today. It will be a mix of the simulated patient task and the structured discussions. So the idea of doing each module separately is because each module gives you one station in the exam. So the stations are chosen with great care, and stations are different most of the stations are different from that of a regular course, and the feedback will be extensive. You can ask questions after the station, and typical stations like audit, risk management, taking bad news, hidden agenda, we make it a point to keep those kind of stations. And then in the end, there are two very different sessions. Angry patient. So these, there will be two such sessions. The first session will be angry patient, talking about complaint procedures in the UK. These will be at the end of the course, dealing with young adults. So we would have already done stations on dealing with young adults, but then we will discuss the important points: sexual assault, Mental Capacity Act, breaking bad news, abortion laws in the UK, the HFEA guidelines. The second topic discussion will have these topics: bullying, undermining, vulnerable populations, complications in surgery, confidentiality, when you don't know anything about the station, how to approach it, disagreement between the doctor and patient, and then labor ward and gynae list prioritization. So how do we prepare with the course? As I said, when you're given a module, you will be given the topics, but prepare the whole module well. In the preceding week, topics will be given so that you don't fumble in the basic things. The emphasis of the discussion will be, or the feedback will be on how you're communicating and how we can improve that. During the session, use the 2 minutes as in the exam. So not only during the sessions, whenever you are preparing, whenever you are practicing with whoever you are practicing, use these 2 minutes with a pen and pencil, with the paper and pencil in your hand. After the session, jot down the important points, make your own templates. I say again and again, people just run after each other's templates, but they are not useful. You should have your own words, your own lines, which you will remember better than anything else. So write down the lines to be said for future reference. As we discussed the case of abnormal labia or that perception, the adolescent girl, you should actually write those lines as I told you, so that you don't have to think in the exam, they come naturally to you. Listen again, analyze, make a separate notebook of these templates, Once you do these 80 plus cases in the course, you can actually print your own book at the end. So you will have a book at the end in September, which will have around 70 to 80 cases. So you can imagine, you can just, when you read it, you will have all written material before you go for the exam. Most important tips: be positive in the exam. Exam is as simple as it appears difficult. Strategic preparation is the key. Understand what the exam is about. Understand what they're trying to ask you. Always listen to the role player. Be calm and confident in the exam. Don't lose your cool. This is the most important tip for the exam. Think that this is a patient in your own clinic, and then deal with it in a similar manner. Be empathetic and caring. So as I said, as I always say, there's a song by Boyzone, which is words. So it's only words, and words are all I have to take your heart away. So words are the most important part of this exam. So you should know what words you are going to speak. So your words should be that worthy that, you know, you easily pass the exam. So whatever you know in your mind, whatever you have read means nothing. Whatever you speak there is all that it takes. So I don't know if Dr. Heather is there to tell about the course. Dr. Heather, are you there?
Yeah,
I think he's left.
I'm here.
Oh, you're there? Oh, okay.
Yes.
Please go on.
Yeah, first of all, thank you for this valuable information. I hope all of our session members have got a good idea about the Part 3 exam now. Okay, let me switch to my screen. Okay. I will quickly explain about the course, and then we will close the session with the question and answers segment. So let's proceed. Okay, so here is a quick summary. Instructors of MRCOG Part 3 Intensive Long Course are Dr. Pooja Sharma, Dr. Sidra Ali, Dr. Mohammed Hassan. Duration of this course is 3 months. It will start in June, then July and August. There will be total 16 plus the introduction sessions, so 17 sessions. We will discuss 70 important cases and in this whole course. We will also give recording to all the students for the 4 months. Like it will expire on September 30, 2019. So the course is for the 3 months, but we are giving recording for the additional 1 month so that you can revise properly. I would like to tell you that only MedExam Expert is offering recordings of the courses. We have observed that none of the other courses, they are giving this sort of facility. So please do not misuse that. Our system is capable. If you log in or share your credentials with anyone else, and if your credentials are being logged in through any other device, so we'll get to know, and that can impose a ban on you for the future services. So please be fair, as we are giving the recordings to give more benefit to the students, as most of the times it happens that there's a duty, there are some other important tasks and they cannot attend the session, so they can revise and see the session later on. The course fee is £550, and either you can pay in the single payment or in 2 installments. So we have mentioned the details on our website. There are basically 2 different modules, one for the full payment and one for the installment payment. So for the installment payment, the first installment you will pay now, and the second one you will pay before July 5. We are also offering discounts. There is an early bird discount. If you registered before 12th of May and do the full payment, then you can get £10 discount on the total fee, and you will be paying £540 instead of £550. There's a very good discount for all the members who have joined our MRCOG Part 3 course previously. and they can get a discount of 15%. So instead of £550, they have to pay £468. The old members who want to join this long course and want to avail the discount, they can just drop us an email or message on the Facebook page, and we will guide them about the discount code. The course joining procedure is very simple. First of all, you have to create an account on our website, that is www.med-examexpert.com. If you already have an account, then you can skip this step and log in. Once you will log in, you will see course catalog button on the right side. Just click that and then go to the MRCOG Part 3 category. You will see a course with the name of MRCOG-3 Comprehensive Extended Course. Basically, there are two courses. You will see two courses there. One, as I told you, for the full payment. One will be for the installments. So you can choose whatever convenient for you. Once you will choose that course and click the Get Course button, you will get the payment page. And once you submit the payment through credit or debit card, and if the payment has been successful, then you will receive a confirmation email, and you will be part of the course. This is a course schedule. The very first session is on June 2 by Dr. Pooja about the introduction, and she'll discuss some important miscellaneous stations. The time for the sessions for the Dr. Pooja will be 2 p.m. GMT. For Dr. Sidra and Dr. Hassan, it will be on 3 p.m. GMT. Most of the sessions we kept on Saturday, but few of the sessions are on the Tuesday. Once you will sign up, we will send you this course schedule. That's it. From our side, please let us know if you have any questions.
So Priyadarshini has asked how many days in a week is the course. It will be once a week, because we want you to prepare. And Indian time, you have to convert from 2 or 3 p.m. GMT. So it will be 7:30 or 8:30 p.m. Indian time.
Yes, 5:30 GMT. I mean GMT plus 5:30. So 2 p.m. means that 7:30 p.m.
Yeah, and not 6:30. It will be 7:30 and 8:30. So 2 and 3 p.m. GMT will be 7:30, 8:30 p.m. India time.
I just want to clarify one point here. The GMT time and the UK time as of now is different because of the time zone change they have made recently. So UK at the moment is GMT plus 1. So if we are referring to the GMT, then just add the, you can say, hours according to your country. By the way, we will also guide you about that. That which country has a which time zone, or you can just Google it. It's very simple. Just enter, I mean, how time converter. So you will get two options. You'll enter the GMT. You'll get your local time.
Okay. So questions. Any courses start in July? So no, the course starts June, because it's difficult to start course every month because it's a long course. It is going to go for 3 months, and then later we will have a regular course before the exam. Each session 3 to 4 hours. It will be there between 3 to 4 hours. So you can say that this session has also gone more than 2.5 hours. So yes, 3 to 4 hours, probably near 4 hours. Anything else? And before I forget, there is another session planned for next Saturday, that is 18th of May 2019. It's a free session on stations. All the 3 mentors, including myself, Dr. Sidra and Dr. Hassan, will be discussing 2 stations each. There will be 6 stations. It's a free session open for all. It starts at 4 p.m. GMT on Saturday, 18th May 2019. We'll be again announcing it on the Facebook. So please join us for next Saturday also. And you can volunteer, and 6 people can do the stations next week.
Yeah. Another important point I would like to tell that in the course, everybody will get a chance to present the station. As there is no, usually in a regular course, we have 2 type of seats, active participants and the listener participants. So only the active participants can, you can say, present the stations. But this time, everyone will get a chance, and the seats are very limited. So if you are interested to join this long course, secure your place in advance. Otherwise, later on, we will not be able to accommodate. As you know that there are total 70 stations, so we have to divide the stations among all the students. So seats are very limited. After this long course, we will be launching our regular course as well before the exam. That will be for the month. If you feel that long course suits you, then you can join this one. Or if you think that you're already prepared, you just want to have a quick revision or practice, then you can join our next course. But joining this course will help you in many ways, as Dr. Puja explained already, that we will be with you with 3 months. We will make a Facebook group. We will add you in that Facebook group. So that will be like a study buddy for the 3 months. If you have any questions, you can ask there, and all the mentors will be helping that. So that's all from my side. If we do not have any questions, we can proceed with the closing of this session.
So Rabia is asking the topics of next session. Next session will be extempore. Yes, who's there?
Hello, I would like to ask one question about
Yeah.
your course.
Yes,
And
please.
as I'm in the government service, if we miss your course during for one day, can we get the recording or some lecture notes?
Yes, we actually record every session. Like this session is also being recorded. So what will happen is that on the very next day, we will upload that recording on our website, and we will give the access of those recordings to you for the 4 months till September 30. So you can listen anytime, whenever you get free.
Thank you.
Thank you.
I'm from Myanmar, so is that 6 hours plus GMT?
Sorry, which country you're from?
From Myanmar.
Okay. We have to check. Actually, we also do not know, you can say, all the time zones
Excuse
by heart.
me.
So the best way is to Google that. You can just enter the time zone converter and mention your.
Myanmar is, I think, GMT plus 6:30, 6.30 hours.
Okay.
Yes, thank you, sir.
Yeah, it will be 6. So please don't ask time in all countries. I think Google is very helpful assistant, and you can easily find it. It takes hardly 1 second to know your time, and then you can calculate and see whether the time is suiting you. Next session, as Rabia was asking, it's all extempore. The topics will be announced in the course. Once we start the course, we'll be giving the topics. Next session will be extempore. It is just to make you aware how to present. It's fine if you don't do well in the initial sessions. I know it's just the starting of preparation. As you go along, you will see the improvements and you will feel it. But yes, it is a continuous effort from your side. You have to practice daily. Anything else? I think, yes, Wong, 2 types of course. This is the long course, which will go on for 3 months. The next regular course, which we have been having since last August, will be before the exam. It will be in around September, October. That will be before the November exam. That will be like an intensive course that we'll be having around 2 sessions or so per week. That will be a 1 month course. This session also will be posted, and then you can listen in who have missed the initial part of the
posted on our YouTube channel, so you can subscribe that and you will get the notification. We will also share the link on the social media and Facebook groups and the page. Okay, thank you everyone. It was nice having you all in this session, and see you in your next session. And before that, you can add your friends and tell your colleagues about the next sessions and the course, and they're also welcome. Thank you very much, everyone. See you. Bye-bye.
Okay, thank you. Good night, and see you next week. Bye-bye.